Hello, my name is Hui Ho, and I'm an internal medicine resident at STA Florida Citrus Hospital. And today I'm presenting the case of early initiation of beta blocker in emergent CABG. Some background information. Long-term beta blocker therapy has been well established in unstable coronary artery disease patients to prevent angina symptom, reduce reinfarction rate, as well as part of the guideline for heart failure which a lot of these patients have. Beta blockers are contraindicated in cardiogenic shock patients, which poses a question because a lot of emergent CABG patients are in cardiogenic shock. When should a patient be started on beta blocker after emergent CABG therapy? Current practice suggests that patients should be started on beta blocker when they are hemodynamically stable and not on any pressor support. This case presents a 66-year-old man with past medical history of diabetes and no other cardiac history, presented with emergency for chest pain. Initial EKG shows significant ST elevation in leak 2, 3, and AVF, and he has significant troponin elevation. Patient underwent emergent cardiac catheterization with showed multivessel CAD, 99% of mid-LAD, 90% first diagonal, 100% left circumflex, 90% first obtuse marginal, 90% RCA. An echocardiography also done and show an ejection fraction of 30-35%. He underwent emergent one vessel coronary artery bypass graft surgery because the RCA was too small for bypass. In post-op day 0, the patient was on 4 pressor, epinephrine, norepinephrine, milrinone, and vasopressin, as well as an intra-aortic balloon pump. Post-op day 6, all pressor were weaned off, the intra-aortic balloon pump was also weaned off, and the patient was successfully extubated. Post-op day 9, this is after 3 full days of stable vital without any pressor support. The patient was started on metoprolol succinate 25 mg oral daily, starting at nighttime. Post-op day 11, after about a little more than 24 hours after beta blocker initiation, the patient became unstable, developed cardiogenic shock requiring dobutamine, dopamine, and CRRT. So the benefit of beta blocker therapy is well established in STEMI patients for chronic angina symptoms, reduced incidence of reinfarction, and also part of heart failure guideline. However, most of the data that support this guideline is focused on long-term, months to year follow-up outcome. So beta blocker is contraindicated in cardiogenic shock due to their negative inotropic effect. The optimal time to start beta blocker in emergent CABG patients who are in cardiogenic shock is unknown. Now, most experts would agree to start beta blocker as soon as the patient is hemodynamically stable, not on a pressor support. However, in this case, this patient would hemodynamically be stable without support for 3 days before starting beta blocker, and yet he still progressed into cardiogenic shock after beta blocker initiation. One likely explanation for this is the emergent nature of the surgery, as well as the RCA will not bypass due to anatomical difficulty. So this case suggests that despite the benefit of beta blocker in CAD patient and heart failure patient, the clinician should be cautioned when starting beta blocker after emergent CABG surgery. More studies are needed to evaluate the optimal time to start beta blocker in emergent CABG, and this is the direction of research that we are pursuing. Thank you and have a good day.